non-suicidal self-injury. This is a behavior where we're intentionally harming ourselves, but we have no intent to die. It really has a different function and a different reason why we're engaging this behavior. Non-suicidal self-injury is kind of the current term we're using for this, and it's been called a lot of different things over the years. And I think that's led to some confusion in the way we treat and study the behavior because we have this mix in terminology. But what non-suicidal self-injury tends to be is insult to the skin. So whereas suicide attempts, we use a very wide range of methods, from obstructing airflow to ingesting poisons to causing serious wounds on ourselves. Non-suicidal self-injury tends to be focused on damage to the skin, and there's some theories and reasons why we think that might be the case. But just to contrast it, probably the most common reason for method of suicide attempts is poisoning. Nobody's really taken poison to harm themselves without intent to die. Nobody's taken things that are going to upset their stomach and cause them to feel sick. They're engaging in things that cause wounds to the skin. We gave you some warning signs and things to watch out for suicide attempts and suicidal behaviors. For non-suicidal self-injury, it's a lot trickier because the non-suicidal self-injury tends to not incapacitate you, so nobody notices you, knocked out or not conscious, and it tends to be concealed. So it's a lot of cutting that goes on or on parts of the body that aren't normally revealed by your clothing, or if it can be covered up, it's covered up. So it's tricky for us to observe and identify non-suicidal self-injury, and sometimes we stumble upon it because we notice more general signs of just withdrawal and depression, and then getting in contact with care, there's further assessment that reveals non-suicidal self-injury. I think for a long time, non-suicidal self-injury was treated as synonymous with borderline personality disorder, but actually we're recognizing that it's associated with a broader range of disorders than just that. About half of people, especially adults, with non-suicidal self-injury probably meet criteria for borderline personality disorder, but that means the other half don't. They have other things going on. So we just need to be clear that this behavior of injuring oneself without intent to cause death is not borderline personality disorder. It might be associated with other psychiatric conditions as well. As we said, surveillance of this behavior is really difficult. So the numbers are a lot more fuzzy than suicide or suicide attempts in terms of the prevalence. We think among clinical populations, like inpatient populations, about half of adolescents, maybe as high as a quarter of adults, will have this behavior going on. The onset of this behavior precedes suicide attempts typically. About 13 or earlier is when we first start seeing this emerge, and there's actually two peaks in terms of the most prevalent engaging in this behavior around 14 and 19 years of age. And it tends to be a behavior that doesn't have a lot of planning associated with it, unlike suicide attempts. This just gives some idea about rates over time. The bottom two lines show all age ranges, across all age ranges for men and women, the rates from 1989 to 2006. And the top two lines show boys in the dark lines and girls in the light lines. And what you can see is there has been among boys, a sizable increase. It's actually gone from about 100 to 200 out of every 100,000 adolescents ages 15 to 24. So it's doubled in the last 25 years. But for girls, it's more than tripled, from about 150 cases to 450 cases per 100,000. So there's an idea that we're seeing a lot more of this behavior going on in the community in cases that we see coming through the clinics. And I'm going to tell you about one model that kind of is currently maybe a leading concept of how we make sense of this behavior. I think for a long time there was the idea that this behavior is a very manipulative behavior where people are trying to take actions to change their social environment around them. And there's been a lot of research kind of getting at that, because for a while we thought, well, maybe intervention should be focused on skills training where people can learn more healthy ways of dealing with their social environment than cutting. And through that work, we've started to focus a lot less on this as a way to change your social environment and more on people engaging in this behavior to moderate or just control their emotional or physiological state. So Chapman has this model. There's a couple different versions of it, but I think they all share a lot of the same characteristics, that this behavior is engaged in to avoid or control the feelings one has. And the idea here is that physical pain is something that they can inflict upon themselves, but also have control over, whereas they have these emotions that just feel so overwhelming and out of control. It's very frightening. So the ability to cause some pain to oneself in a way that they can control is actually a reassuring thing. According to Chapman, there's some certain subgroups that have deliberate self-harm, like psychosis or developmental disorders, or even just be endorsed by a subculture one participates in. But there's a whole bunch of other kids out there who don't have any of these problems going on, but still make up probably the majority of those with non-suicidal self-injury. So what's going on with them? And that's what the purpose of this model is to explain. It's just this escape or avoidance. So how's this work? Well, we all know things happen in life that just don't always go our way, and we usually don't like that. And so we have these triggers or stressors that go on. They result in physiological arousal and emotional reaction. And what we have to do over time is learn that, well, there's certain things I can do to try and, deal with that frustration. And having experienced that process of being stressed, having a physiological emotional reaction, and then dealing with that, even if it's a matter of waiting it out until just time passes and your body can calm back down, that experience over time leads to this idea of distress tolerance. It means you can be in a state where there's something stressful going on, you feel uncomfortable, but you've learned that you can handle it and you can be okay with that. Well, non-suicidal self-injury, we think, steals that opportunity from kids. So what happens with, according to this model, the stressors that are experienced is we get these intense emotional and physiological reactions. And especially at the time that these behaviors are emerging, 13, 14, 15 years old, we don't have a ton of skills for dealing with intense emotional reactions. So these behaviors may be tried. And what we learn when we try these is that actually they work. What they can do is they can lessen the physiological arousal that we're experiencing because of the stressor, and actually clear our mind even a little bit. So we think that's why this dermal wound is the method that people use for non-suicidal self-injury, because one effect that has is that when you have a skin injury, your body releases its endogenous endorphins and opiates in your system. It's like a natural painkiller. It can reduce the discomfortable physical feelings you can have, but it also can induce a sense of calm and not euphoria, but a sense that can take away those feelings of being overwhelmed emotionally and make you feel in like a more peaceful state temporarily. So besides that, a lot of people kids in this situation say they just feel so overwhelmed they can't think of anything else. And they can't think straight enough to even engage in a maybe more healthy emotional skill regulation behavior. But that cognitive distortion they have can be taken away by this non-suicidal self-injury just because it's such a distraction. When you see the sight of blood for many people, really focuses your attention quite a bit and can take your mind off of those things that have been so overwhelming for you. So that's the tough thing about this behavior. It's a behavior, unlike attempts, which may happen one time and never happen again, Non-suicidal self-injury tends to be a behavior that people engage in a lot, and it becomes almost like an addiction. And the reason for that is because these things immediately kind of reinforce or take away the uncomfortable feelings you had that got you to exhibit the behavior in the first place. So besides it just not being a healthy way of living to begin with, it causes a lot of other problems over time. So one problem is it kind of lowers your physiological threshold for becoming aroused. So your system very quickly over time goes from experiencing these triggers to your physiological arousal going through the roof. And at the same time, it prevents you from learning new emotional regulation skills. So the more practice you have at doing this behavior, the more quickly you progress from experiencing a trigger or something that's distressing to a high rate of physiological arousal and distress to non-suicidal self-injury. So it becomes almost like an automatic behavior after a short amount of time, and that makes it really difficult for us to intervene and replace that behavior when we're treating these kids. So how do we do the treatment? Well, the first thing we have to do is take away avoidance behavior, and that's taking away not just non-suicidal self-injury, but replacement behaviors. Another replacement behavior for this is substance use, which we also know is a big problem among teens. You know, as long as you're engaging in either hurting yourself on purpose by cutting yourself or intoxicating yourself, you're putting yourself in a state where you can't learn distress tolerance and you can't learn emotional regulation skills on your own. If we can prevent avoidance behaviors, we need to allow that person to safely be in a place where they're experiencing some emotional discomfort. We're going to work with those kids to learn what are other things you can do when you feel overwhelmed emotionally and things that are more helpful. And over time, having experiences with being in that emotionally intense situation but being safe, you know, they can experience increases in distress tolerance, and their confidence and their ability to withstand stressors grows. So acutely, non-suicidal self-injury is reinforced because it just solves this issue of feeling intensely over-aroused and emotional. But chronically, it actually can lead to you becoming more emotional and more easily aroused, even for minor stressors over time. So the amount of situations that result in non-suicidal self-injury just grows and grows and grows, and it becomes a mechanism that is like a habit or addiction. And in order for us to kind of remove this behavior, we have to stop the avoidance behavior and teach them new ways to be in an emotional or arousing situation safely. Okay, so hopefully by now I've convinced you that non-suicidal self-injury, suicide attempts, and suicide are all things that we should be concerned about when we're working with adolescents and early 20s. And we've talked about some ideas on why we think these behaviors might occur. Regardless of which model you're interested in, a lot of us are thinking that suicide attempts involve an interaction with some acute stressors, interacting with some underlying vulnerability, and non-suicidal self-injury is just a mechanism for controlling one's emotional or physiological state. So the question that leaves us with is, well, what do we do? You know, now that we realize that this is the state that we're dealing with, and how can we intervene and change that over time? I'll let Dr. Sheftal come up here and tell us about a couple therapies that address those.